Now, this is a very interesting ECG. You can simply see, you can pause the video for a second and you can try to figure out what could be the problem or what is the problem in this particular ECG. Now, when we see that it is crystal clearly written that the heart rate is around 107, and this is reading that patient has premature atrial contraction. So, heart rate is more than 100, so it is tachycardia. More than 100, we call it as tachycardia. Now, what is the reason for tachycardia? It can be sinus. So, if it is sinus, then each and every QRS has to be preceded by same P wave, same atrial contraction wave, which is P wave. But here we are not able to see same P wave. So, if you zoom out and you see, we know that our heart rate is constant. It is in between 60 to 90 usually. If it is more than 100, still the P wave remain constant in particular wave, in particular lead. Why it is so? Because we know that we have the atria and we have atrial pacemaker, which is SA node, which create or which begins this P wave, atrial contraction. So this is always almost constant. This sinoatrial node is constant. That is the reason why the P wave which is originated is always constant in morphology. So P wave morphology, P wave structure has to be constant in every particular lead. So whenever in this case, what we can see the P wave, see here, see here, see here, see here. So he see here. So in this particular ECG, there are different morphology of the P waves. This I will tell you this. These are different morphologies. So this P wave is different. This is one morphology. This is a different morphology, and this is totally different morphology. So there are total three different morphologies of P wave, which we can see in this particular ECG. Here also, P wave is here. This is notching. So this P is different, this P is different, and this is totally different. So there are three different morphologies of P wave. If you can see in all leads, you can see the same thing, that this morphology is different. This, they are same. So these two P waves are originating from the same atrial focus. But see, here is the notching. This P is totally different, and this is totally different. So this is T and this is P wave. So we have different morphologies. This is one morphology, this is second morphology, and this is third morphology. So in short, in SA node, in atria, we know that uh, some P's are originating from one side, some is originating from other side, and some is originating from the third side. So there are different locations, there are different pacemakers which are causing P waves, which are getting conducted to this AV node and which are getting conducted to the ventricle, left and right ventricle. So this is tachycardia with three different P waves. So we call it as multifocal atrial tachycardia. So this is typical of MAT, that is multifocal atrial tachycardia, because there are three or more than three P waves. So to label it as MAT, we must have three different P waves. This is mostly because of the atrial damage. That could be because of pressure overload, volume overload, or because of MI as well. So, right, just like the disorders like MS, MR, RVH, or TR, TS, these type of disorders which actually damages the atria can lead to fibrosis and multiple atrial foci working as a pacemaker. So this is typical of MAT. The treatment is to correct the underlying problem, and this MAT, the heart rate can be reduced by beta blockers or calcium channel blockers like dilsem, verapamil. So this is all about today. Thank you.